Hi, everyone. Thank you for joining us tonight. We're really excited for tonight's topic that's discussing CAMBRA and ethics in dentistry. So before we get started, there's a few things to mention. If you have questions tonight, please type them into the questions box on the right-hand side of your screen. We will have some time at the end for Q&A. And if anyone wants to learn more, please feel free to contact us to schedule a meeting with you and your team. So with those things out of the way, I'd like to introduce Dr. Kim Kutsch, CEO and founder of Carifree. Dr. Kutsch has been successfully practicing dentistry for 35 years and still practices 3 days a week here in Albany, Oregon. He's the world's leading authority on ATP as it relates to caries risk assessment. So Dr. Kutsch, I'll let you take it from here.
Thank you so much. Well, welcome everybody. I am excited for tonight. I am fighting one of those summer colds, so my voice is a little gravelly, but we'll get through this. This is really an interesting topic, and I think it's very timely as well. I mean, I think timing is everything, and I continue to hear questions like, you know, is CAMBRA the standard of care? And so I really want to kind of go into that topic tonight with you so that I may not be able to give you a clear answer on that yes or no, but I can give you enough information that you can make that kind of answer that question for yourself. So when my team first posed this idea of ethics, I thought, yeah, that sounds interesting. Let's take this on and really dig into it and examine it kind of from all sides. So I want to talk about ethics tonight. And if we start, you know, with the definition of ethics, it comes from the Greek word ethos, meaning, you know, your character or your conduct. And it's used interchangeably with the Latin word mores, you know, which we bring the word morals from, meaning customs or habits. I'm not sure why the prescription is on this slide, but so we're talking about ethics as our moral character and our conduct. And as dentists, we have an ethical duty, and really in 3 areas. We have an ethical duty to our patients, we've got an ethical duty to our professional colleagues, and then we also have an ethical duty to society in general as well. And the ADA actually has a code of ethics, and the code of ethics is built on 5 principles, and these 5 principles we're going to go into kind of one at a time, but it really kind of creates, these kind of principles really create the essence of being a professional, where you really put the needs of the person ahead of your own needs. You know, I think my best definition of ethics would come from Gordon Christensen years ago, who I remember saying, you know, it's doing the right thing for the right patient at the right time. And so it's really about doing good. But if we look at these 5 principles then in our ADA Code of Ethics, number 1 is patient autonomy, and we'll talk about that. Nonmaleficence, beneficence, justice, and veracity. And these principles kind of overlap each other, and then we also have a code of conduct, professional conduct, and then we also have advisory statements as well, opinions. But if we start with, I think it's kind of interesting looking at this, because I've been reading quite a bit about this, obviously. But in the medical profession, they have basically their code of ethics includes autonomy, non-maleficence, beneficence, and justice. But they leave, you know, veracity has been added by us to our profession. So let's talk about those. Number 1 is patient autonomy. And this comes up whether you're talking about evidence-based dentistry, and which we're going to talk about tonight as well. But you know, we have the duty to respect our patients' rights to self-determination and then confidentiality. So it's like, we always need to take into consideration, what does the patient need? What does the patient want? You know, we need their input. You know, ultimately, at the end of the day, we work for our patients. And so we want to include them in the decision-making process so that they fully understand and that they're making good healthcare decisions for themselves, and they're being able to make that maybe with your guidance or your help or your advice or your opinion, but ultimately at the end, they're the person that makes a decision for themselves about their health. And so that's really, I think, the basis of all of our professionalism in terms of ethics is, you know, starting with the fact that the patient's in charge. And so we need to keep that, and then also safeguard their privacy. And certainly we know with all the hacking and things that go on, there's an issue now with that in terms of all of our electronic charts and what have you. The next principle is non-maleficence. Now, maleficence is different from the legal term malfeasance. Malfeasance is defined as doing harm or doing wrongdoing. Maleficence is defined as doing evil. And so, I mean, there's a huge difference between doing evil and just doing wrong. So non-maleficence then is, you know, we've got the first responsibility is to do no harm to our patients. I mean, the one thing we need to do is keep our knowledge as current as possible, know what our skills are, what our limitations are, and knowing when to refer somebody to another professional if we're not able to make the diagnosis or if we're not able to, you know, adequately provide a good treatment outcome for that patient. So that's part of our responsibility in ethics as well. So that's non-maleficence. Now, beneficence is, at the same time, we want to do good for the patient. We need to look out for their welfare, put their welfare ahead of ours. And, you know, this is, again, for us to be competent, you know, provide our care timely and within the bounds of, you know, clinical circumstances, and do consideration of the patient's needs, desires, and values. So it doesn't matter whether you're treating a patient in a fee-for-service or managed care or even a pro bono situation. You know, we need to make sure that what we're doing is helping the patient and not harming them. Justice is we need to treat everybody fairly. You know, we need to look at every patient without prejudice. We need to be able to take that patient in and, again, treat them all the same in the broadest sense. So this is really, I think that I see this a lot in our profession. I think that we do an admirable job of helping. I mean, dentists and hygienists, I mean, in the dental profession, truly we are a caring profession, and you know, we care about people. That's why you're a dentist. That's why you're a hygienist. That's why you're in this job, whether you're a dental assistant or at any member of the team, because you care about people and you want to make sure that everybody gets treated with dignity and respect. Everybody deserves that, and that's, again, part of our ethics. Veracity means that we have the obligation to be truthful. You know, so we need to be truthful with our patients. You know, if you think it's a good idea or a bad idea, you know, we need to be honest and upfront with our patients. And, you know, this sets our profession aside from maybe a lot of other businesses in the world. But it's interesting. We used to be #1 of the most trusted professions in the country. Dentistry was, I mean, every year was #1. And then there was this had to be like in the early 90s, there was a Reader's Digest issue that came out. I'll never forget this. And they had sent a decoy to like 29 different dental offices and got 29 different treatment plans. And they really raised this, you know, red flag of like, oh, you can't trust dentists because, you know, we should have gotten all the same treatment plan. Well, you and I understand that if you went into a dentist, you're going to get a different treatment plan based on their experience or knowledge and what they think is appropriate or what they might recommend for the patient. So we've slipped to #5. We're currently the 5th most trusted profession. Nurses and physicians, pharmacists, and engineers are ahead of us. Interestingly enough, the least trusted profession in the country are members of Congress, and they are just above used car salesmen in terms of trust. So being trustworthy, you know, being honest and truthful and direct with our patients, I think is a really important part of our ethics as well. Then we also have the ADA, we have the Code of Professional Conduct, and that really is guidelines on how you take those, our ethics, and how you apply them in terms of how you behave. You know, and whether it's, you know, how you communicate with the patient, you know, your level of professionalism, you know, that's all covered in the Code of Conduct, you know, how you treat patients, conversations that you have, et cetera. Again, maintaining confidentiality. And so this really is adopted by the ADA from the House of Delegates, and it's examined, you know, re-examined periodically, and then, you know, they make recommendations on things that may result in disciplinary action if you don't, you know, if you don't conform or if you violate, you know, the Code of Professional Conduct. And then we also have advisory opinions that come out of the ADA's Council on Ethics, Bylaws, and Judicial Affairs, which really is an opinion on how the ADA may respond in terms of a disciplinary hearing, depending upon what, you know, the behavior or misbehavior was. So we have all of that coming from the ADA. So that's kind of our professional cornerstone, if you will, in terms of our ethics. And then we also have the legal aspect. And so we're held to a legal standard of care. Now, this is a real challenging issue when you start talking about standard of care or what are best practices, standard of care, those types of terms, because that's a moving target as well. And the ADA, again, examines from time to time, periodically, what is the best standard of care? What is the best practice? Because as technologies develop, as techniques change, certain things that may have been experimental or kind of out on the fringe have become mainstream, and they have demonstrated scientific outcomes that are better. And so that standard of care changes. So this is always a moving target. Now, the other interesting thing about the standard of care is that also gets defined for us and tested in the courtroom. And judges and juries oftentimes set the boundaries on what the standard of care is. And when you talk about standard of care, the legal definition of standard of care is legally defined as the degree of care that a reasonable and prudent dentist would exercise under the same or similar circumstances. Now, that's also an evolving, moving target, that definition, because I know of cases that have been tried, and the defense attorney was able to convince the jury that the dentist, it wasn't what a reasonable, prudent dentist would have done, but what a reasonable, prudent dentist should have done. And so just because a reasonable person wouldn't have done this, maybe there's a term called customary negligence, where if you look in the entire community, nobody in this small community of other practitioners maybe would have done an implant because they didn't have the experience or knowledge or whatever, or wouldn't have provided some service. Doesn't mean that that couldn't have been considered standard of care. So this is a bit of a touchy issue, and again, it gets defined for us, I think, in terms of the boundaries by judges and juries, and certainly the ADA can help make recommendations, and we have this perception of what is standard of care, but it comes down to really, what would a reasonable, prudent dentist do or should have done in those same circumstances. And sometimes, like in the medical profession, they look at it as a member in that same community. And in dentistry, we really look at it more of just in terms of, what would you do or what should you have done. And so, like I say, standard of care is a moving target. It gets reevaluated by the ADA, and they make recommendations as well, try to help define it so that we're all providing the best care that we're capable of or that we know is available for our patients. But again, standard care is a moving target, and it's really defined, and I think the boundaries are set legally in the courtrooms. Now, you talk about legal versus ethical. Like, our bare minimum behavior requirement is for us to work within the law. So we can't violate laws. I mean, that's the minimal behavior. And ethics kind of begin where the law leaves off. And so as a dentist, you can actually be within the law and not committing malpractice, but still be acting unethically. And, so I read this and I thought, well, that's interesting. So I want to think of an example of where I might be within the law and not committing malpractice, but still acting unethically. And certainly the most obvious of those is informed consent. And if you take just strictly a legal approach to informed consent, all I have to do legally is make sure that I've given the patient the information, I've given them a full explanation, the other options for care, the advantages and disadvantages and potential outcomes and bad outcomes, and I give that to the patient, and they read it, and I communicate it to them. I answer whatever questions they have. They sign the document, and legally I have provided informed consent. Now, ethically, if you think about it, the patient may not fully understand what you are saying to them in terms of describing a procedure or offering other alternatives and what are the benefits and the risks and the outcomes. So from an ethical standpoint, it's not only important that you provide the legal approach, but it's also important to make sure that not that the patient got the explanation, but they understood the explanation. One of the things that I had queued up for this presentation, and we'll talk about it before we quit tonight, is the little girl, the 3-year-old that died in Sacramento just a month ago. And, you know, she died under anesthesia, you know, having dentistry done. And again, that's a huge issue, and we lose children every year in the United States, you know, to anesthesia undergoing dentistry. And we really don't even have a number of how many those are, because states don't, they don't give that information out. And so we know that a young man died just post-operatively, you know, recently from having his wisdom teeth extracted in Texas. And I mean, this happens on a fairly routine basis, and it's a concern. And the point that the mother made of this little girl who died last month was that, well, I didn't really understand. Yeah, they gave me all the information, but I didn't understand that my daughter could actually die from having this done. And so I think it's really important for us to understand that patients don't always understand. We can give them the explanation, and you ask them, do you understand? And they, you know, they don't want to look stupid. I mean, so they shake their head, yes, oh yes, I get it. And they trust you, and so they go forward, and maybe they didn't fully understand what was happening there. Another example, I think, where you could be within the law and maybe a bit unethical is, I know you guys have seen the cases, at least certainly I see them on Facebook from time to time, where somebody will post an x-ray, and some dentist put in like 28 implants, you know, single tooth implants on a patient. And it's like, well, maybe that's exactly what the patient wanted. They wanted to be able to floss in between every implant. But I mean, there's certainly, I have to question, you know, did the patient have the option or understand that they could have had an all-on-4 and what that appliance might have looked like? Or, you know, at times I see that and think like, it's amazing to me. So, you know, legally, you know, if the patient wants 28 implants and they're missing all the teeth and they can afford it and you want to do it, I mean, you know, there's nothing illegal about that. But I think there's certainly other alternatives that are a lot less expensive and may provide a better outcome, that I think, you know, we should certainly give the patient those options. If we talk about ethics and evidence-based dentistry is really, I think, in my mind, helps us establish what the standard of care is. It has to be evidence-based. And so in terms of evidence-based, we have, and you're going to see this term, we have an obligation. We have an obligation to make a conscientious effort to derive a treatment plan based on our best scientific evidence through careful, thorough evaluation of our relevant scientific literature that's current. And we have an obligation to refer the patient when we're not up to date on the best available evidence. And we have an obligation, again, this comes up, the patient's autonomy, to involve the patient's values and preferences in treatment discussions. So this is where it becomes ethically derived and evidence-based treatment decisions, when the patient fully understands what their options are and they're involved in the treatment planning and decision making. And that's really evidence-based. I borrowed this from Doug Young. I've heard Doug speak many times and talk about, you know, evidence-based dentistry is a three-legged stool. By the way, I want to thank Ed Zinman tonight. Ed's an attorney from California, state of California. He and Larry Jensen put on a presentation on ethics that, you know, helped me put some of this material together. Certainly John Featherstone and Doug Young. I've taken information in my education from all of those individuals, and so I really want to thank them as well tonight. But Doug Young likes to say that evidence-based dentistry is a three-legged stool. One leg is your best scientific evidence. Number two is your clinical judgment and experience as a clinician. And then number three is the wants and needs of the patient. So when you've got all of those three together, you have evidence-based dentistry. It's not only just what's in the scientific literature, but it's also your clinical experience and your knowledge and judgment. And then, again, the patient needs to participate in what their needs and values and wants and desires are as well. When we look at the scientific evidence alone, in evidence-based dentistry, I mean, at the very top tier, we have systematic reviews and meta-analysis. Now, scientific studies are becoming more and more expensive to do, particularly random controlled trials, and they take longer and longer to complete. Like I'm working on a random controlled trial, participating as an investigator right at the moment, and it's a, it's like a 1-year trial. It's probably going to take us, anywhere from 6 to 9 years to complete. Just, being able to recruit and get all of the adequate patients and the controls that we need, going through, IRB and, making sure that everything is being done correctly. These studies now cost millions of dollars and they take years to complete. So I think as a profession, we were spoiled by, we had all of these systematic reviews and meta-analysis that were available to us for so many materials and procedures and techniques for so many years. And we are now going to have to start making our clinical decisions based on fewer studies, because the reality is, the government, the NIH is not funding as much. There have been budgetary cuts. These things cost more. They take longer. And so we're really now focused on having to make decisions, maybe without all of this, abundance of systematic reviews or studies. But then we've got primary studies, random controlled trials and cohort controlled trials. You've got expert consensus guidelines. You have the Scientific Advisory Committee for Scientific Affairs from the ADA. They put experts together and go, what in your opinion is like the best care or the best procedure, in this clinical situation. Then you've got your own personal accumulated clinical experience, which is extremely valuable. You've got the expert opinions of other experienced clinicians that you know, and then at the end of the day, we've got logical rationale. And does it make sense? Maybe we don't have all the scientific evidence for it to begin with, but it's like when we started practicing CAMBRA, when I started with this 17 years ago, I had dentists argue, well, show me your studies. And it's like, well, you know what? This is logical. And anytime I look at something like this, you always have to ask the question, what's the risk and what are the benefits? And when I looked at CAMBRA, I saw no risks. Doing a risk assessment and trying to diagnose why a patient had cavities is not, there's no risk for the patient or the dentist doing that. And there's a potential benefit that maybe we'll figure out why the patient has all these cavities, and maybe we'll be able to help the patient, counsel them, and do some coaching for them and help them get healthy so that we're not just on this endless cycle of restoration and re-restoration. So, at some point in time, I started practicing CAMBRA. We didn't have all the studies that we have today, but it was logical and rational. And so it's like, you look at the risk versus the benefit, and I couldn't not do it. So the question I get asked frequently is CAMBRA standard of care? Well, let me share this with you. It is in my practice. And if I were called as an expert witness, I would testify, in my opinion, yes, it is standard of care. It meets these criteria. Number one, it's evidence-based. We have studies now that demonstrate that it works, that it's a benefit, and there's a better outcome. It's being taught universally in dental schools. It's part of the curriculum in every dental school now in the United States. It's being adopted by a lot of clinicians across the country now at different paces and, at different rates within their practice, but it's being adopted. We've trained probably close to 6,000 dental practices here through Carifree across the country. So at some level, there's thousands of dentists in the United States doing this. It provides better outcomes for the patients. We've established that in the scientific literature. And then I know that there have been a couple of cases where dentists were actually found guilty failing to diagnose. They treated the patient's cavities, but they did no risk assessment. They did not diagnose what was causing their decay, and they lost. So I think in a courtroom, from a legal challenge, again, that's one of those boundaries. So it's a moving target. Could you definitively say that CAMBRA is standard of care? No. But is it customary negligence that's going on? I don't know. All I can tell you is it meets all of these criteria, and in my practice, certainly it's standard of care. One of the challenges we have is with the adoption rate of CAMBRA, and we're going to talk about that tonight. But I've got a picture of honey here on a spoon, but it's actually slower than that. It's glacial. If you think about the fact we have 140,000 practitioners in the country, and maybe 10,000 at best are practicing CAMBRA at some level, and this has been going on CAMBRA's been around for 17 years. This is a glacial movement within our profession. I mean, we are very slow to change. We have scientific evidence. This is from 2014, and they did a survey with dentists and said, you know, why is this not happening? You know, it's clearly a better outcome. Why aren't dentists doing this? Well, number one, the result of the survey was dentists, number one, didn't know how to do it. They were confused by it, didn't feel comfortable, didn't feel like they adequately knew what they were doing, and number two, didn't understand how can we charge for this, how can we be paid for our professional time to make this work for both the patient and our practices. So, you know, that's one of the things creating the problem with the CAMBRA adoption. And this was a survey that went out, 547 general practitioners in the state of Texas, and this was published in 2015. And a substantial percentage of the dental practice-based research network dentists do not perform a caries risk assessment, and there wasn't a strong linkage between its use and then the use of individualized preventive regimens for the adult patients. So it's like not very many dentists were doing it, and the ones that were doing it didn't really have a correlation between what the results were and what they recommended for the patient in terms of the regimen for them to correct their issues. So, you know, that's a challenge for us. So caries risk assessment is being done, but not widely. And then, you know, hygienists. This came from the Journal of Dental Hygiene in 2015. Again, CAMBRA has not been widely implemented in hygiene operatories across the country as well. And again, there's a number of barriers there, but they're not insurmountable. This is my hygiene team, and we've been practicing CAMBRA as a standard of care for 15 years in my practice. But you really need to involve your entire team. If you want to be successful at this, everybody has to be on the same page. Everybody has to feel the same way about it and understand that that's the standard of care. That's in our practice. That's how we do things. And they need to understand why it is. Like, what are the risks and what are the benefits? What are the benefits for the patients for us doing this versus not doing it? And I think at that point in time, every hygienist who, again, anybody that cares about their patients is going to be on board with that. If we look at change, and I love this book. I read this the first time probably almost 25 years ago. And if you haven't read this, this is really a good read. The Structure of Scientific Revolutions, and he wrote this originally in 1962. It's been revised, and I think there's 9 editions out now, something like that. But what he did was looked at, like, why does it take so long for there to be change? And number one, he starts with the old guard is protecting their existing turf. Like, you know, I don't want to change. I like, you know, what we've got works. It's like, I've got all the reasons why we should continue to do things exactly the way that we do it. And you'll come up with scientific studies, and I've seen this happen over my career, which when I first read the book, I thought, no, that can't possibly be true. But you can have a scientific study come out, and I can look at 2 people who will read the same data and the same results and come to the exact opposite conclusions. The old guard will say, see, this is why I told you it doesn't work. This proves it doesn't work. And you'll have the new guard look at it and go, see, this is the evidence that proves that it works. And you think, how can 2 people look at the same data and have the total opposite conclusion? But that's part of our human nature. You know, it's our confirmation bias. We're looking for, in those studies, to confirm what we already believe, what our paradigm is. So there's a period of crisis going on where, should we be doing it? Should we not be doing it? And you've got this challenge and struggle, and I know that happened in the dental schools in the last 17 years. It finally came to a pretty good consensus about 3 or 4 years ago, and it's now really universally being taught. And then slowly the new paradigm gains acceptance. And one of the conclusions that Thomas Kuhn had in his book was that, and sometimes this is a generational thing for change. Sometimes the old guard just has to die, and then finally things change. Now, I'm not advocating that anybody in our profession needs to die, but I think that, sometimes for change, it's a generational change. When I looked at this, CAMBRA 17 years ago, I told John Featherstone that this would be standard of care. We'd make this standard of care in 10 years. Well, that obviously didn't. I figured every dentist in the country would be doing it in 10 years. Well, that's 7 years ago, and it is still not every dentist is doing it, but all of our students are now being trained on how to do it, and we are slowly making a change. And it's probably, as I've become, I think, have better perspective and I've become more mature, I realize now that this is probably a generational change. But the good news is we have the movement, it is moving, and it is changing. If we look at some of our scientific studies, this is a systematic review that came out in 2013. Baseline caries prevalence was the most accurate single predictor for future caries experience. And one of the challenges we've got in some of our studies is the heterogeneity of the populations, the number of people involved in the same studies, the study designs, and if, for our prediction models, really need to be validated in at least one independent population. So, I mean, there were some challenges with some of our early studies. But then I look at studies like this report. This was the National University at Singapore, and their caries risk assessment model reached a combined sensitivity and specificity of 160%, or 1.6. And that's the gold standard for a diagnostic test. 160% combined sensitivity and specificity, that is the gold standard, which means 80% of the time you're going to have the right diagnosis, either positive or negative, but 20% of the time you're still going to be wrong. And I think for dentists, we struggle with, I want it to be 100% right all the time, and diagnostic tools, don't really work that way. I mean, some of them are as poor as, they're only accurate 25 to 50% of the time. But here, I mean, it meets the gold standard in terms of caries risk assessment. So we know that we have the scientific basis. This was a Featherstone paper that was published in 2015. These results lend evidence that baseline caries risk predicts future caries in this setting, supporting the use of caries risk assessment, to identify people that need more intensive preventive therapy to help prevent this disease or future disease. So it's certainly, our caries risk assessment is a valid baseline predictor. And then this was a review in Inside Dentistry in May of 2015. It really talks about, it's an excellent approach to manage and treat both gum disease and dental caries, treating those dysbiotic biofilms and making that part of our standard of care, part of our standard regimen within our practice. So we have the scientific, I could have presented a lot more scientific studies on this, but we have the scientific evidence behind this to support you doing it. And this is an interesting book as well that you might, this is an interesting read. And it's really, again, talks about adoption of innovations and what the challenges are to that. And it's kind of like Thomas Kuhn's Scientific Revolution, the structure of scientific revolutions. Is the new innovation better than our current methods, right? And, so I asked the question, is CAMBRA better than a non-CAMBRA type diagnosis, quote unquote? And I mean, in my mind, absolutely it's better. There's an advantage in terms of treatment outcomes. If you don't address what's causing the cavities, the patient's going to continue to have the disease and, ad infinitum. This is a paper by Michelle Hurlbut and Doug Young that was published in Evidence-Based Dentistry in 2014. And it's really, caries management by risk assessment has emerged as a new paradigm in patient care, and it represents an evidence-based best practices approach with a potential for significant advantages over traditional methods. So, you have better outcomes, you have more predictable outcomes. Anytime that you can do that for a patient and put them in control of their health with a better understanding of what's going on, it's a win-win. The next question is the innovation compatible with our existing values and habits? And I think CAMBRA struggles a little bit with this because I think practices are so heavily focused on restorative dentistry and restorative procedures. And actually, Bob Barkley in the early 1970s, his biggest concern about dental insurance was that it would drive the patient or the profession more and more toward restorative procedures and less prevention, because you could document and prove that you did a filling, but whatever hour you spent on patient education, you can't prove that you did something. There's not an x-ray that they can look at. And so his concern was that we would move away from prevention and move more and more toward, and we have the newest Windows feature update is here. And I'm not sure which one of these to hit, but I know it's not restart now. So we will pick a time, and that time is going to be next week, tomorrow. Okay. Perfect. So we're back. So one of the challenges that we have today is that our profession has become more and more restorative based, surgically based, rather than preventive based. And I think some of that's been driven by, the dental insurance companies. We do a lot of restorations on teeth, and because we can verify that we in fact did that. So that's a challenge. It's compatible, but our profession is really focused on restorative, and now I'm not advanced. Oh, here we go. Finally, we're advancing. Let me back up for a second. Okay. So this is Willamette Dental Group, and they've implemented caries risk assessment as a standard of care. This is a large corporate group here in the state of Oregon. I mean, last I knew, they had like 106 dentists practicing in their facilities, and they have been able to, within their entire organization, create, and my hat's off to them, I mean, they've been able to create a risk assessment-based clinical decision tools, and they've made it work, and they've done really well with that. So, it can be done. It can be done in a large group as well. Certainly, it's there and available, and you can do it in your practice. The next question is the innovation, is it divisible? Can you test it? Can you try it out? You have to go in, for the full meal deal, or can you just take it for a test drive and see how you like it, see how it works in your hands? And, it's easy for us to test a new composite material. I mean, they give you the free tube, and you do a restoration with it, and maybe you do one on an extracted tooth, and you decide whether you like it or whatever. CAMBRA is a little more challenging than that, but I think one of the things that I see happen a lot with practitioners are, there's in the entire spectrum. Some people go in, they go jump in the deep end of the pool, and they do it, on everybody. And then we've got some practices that, kind of tiptoe into the shallow end of the pool and go, I'm going to test this out on, I'm going to go back to my practice, and I've got 6 people I can think of, because you know who they are. Those patients that come in every 6 months and they have 2 new cavities or 3 new cavities. I'm going to go back and I'm going to try it first on just those patients. So I'm going to test it there. And so I think that CAMBRA is divisible. I think you can test drive it on a few patients and see if it works. The challenge is, how complex is it? And I think this is where we've really made some errors, if I could, as a group, be critical of our own work. I spent the first 10 years, 12 years making it complicated, and I've spent the last 5 years trying to simplify it. And every year I try and simplify it more. And this is where my paper, The Usual Suspects, which you guys usually hear me talk about, saliva, diet, and bacteria, I mean, it breaks down primarily to those 3 categories. And, genetics is now in there, but, as a wild card. But we need to break it down and make it simple. And I go back and I look at some of our recommendations and some of our treatment decision trees and some of the stuff in our risk assessment forms. I mean, I saw risk assessment forms from some universities that were 4 pages long. And, that may work fine in a dental school setting where you have 1 student and a patient, and he has a 3-hour appointment to do this in. But, in a dental practice, if you're going to put a 4-page risk assessment form on your hygienist operatory in that 1-hour appointment, expect them to fill that out, you're going to have mutiny on your hands. So it's like we've made it way too complex. And, patients, we need to make it simple for the patients as well. So like I say, CAMBRA needs to be made simple. It can be simple. I've simplified it in my own practice. We really focus on those 3 usual suspects, saliva, diet, and bacteria. And, my patients hear that until, I say those 3 words, it's like a mantra for me until my tongue bleeds. But you can make it simple if you break it down that way. And we've made our risk assessment form simpler, trying to focus on those main 3 categories of risk. And then the last question is, can the innovation, is it communicable? Can you talk to your patient? Can they understand it? Can they see it and feel it and experience the positive net effect? And the answer to this is yes, but maybe not today. It's like, it's a leap of faith for a practice to actually get involved in CAMBRA, because, what you're really doing is the patient may not have a total appreciation for this for a year or maybe 2 years. And when I first started doing this, I did it just out of my own belief that I had to do this. It was a better outcome. I was done just drilling and filling until people ran out of cavities or died. And I really wanted a way to be more effective at treating my patients who happen to be my family and friends at this point in my career. And so looking out for their best interests, which is, I believe, that's my ethical obligation to them, I really wanted to do this. And I thought I was probably putting myself out of business, which I thought that'll be great. It's about the time I'll want to retire. All my patients won't need me anymore. This is perfect. Timing is perfect here. But the reality is, a couple of years into this, patients, who have had cavities their whole life, and they kind of just come to expect it. It's like, suddenly it's just like normal to go to the dentist and have cavities, and it's a mystery as to what causes them, other than I probably don't floss. I know I don't floss as well as I should. I know I don't brush as well as I should. But, and I know my diet's not perfect, but, they have this just big kind of mystery over this. And I think it takes a couple of years for those patients to really, truly experience that. But if you get somebody that listens and participates and makes change, it's the most impactful thing that I've ever witnessed in my career with patients. And I have patients coming in then a year or 2 years later asking for huge restorative plans, because now that they're healthy, they want a beautiful, attractive smile, which they were afraid to invest the money in before because they didn't trust themselves or their own health, that that would be a waste because that crown that got decay under it, or the root canal that failed for whatever reason, and they didn't trust not only the outcome for the dentistry itself, but they maybe didn't trust their own ability to care for it, or didn't understand what it took. And I just had it. So is it communicable? Yes, it is. I think you can explain it. Patients can see it and feel it. I had a dentist, just last week, sent me this long email with this experience that he had with a patient who had been, had severe decay their entire lifetime, and now they've been decay-free for 1 year, and they suddenly came in and wanted a beautiful smile, and he was just absolutely amazed. He said, "What you said was absolutely true. It happened, and I've been saying this for years, but it's absolutely the truth." One of the other ethical issues in terms of treatment, and again, I'm borrowing material here from Doug Young, who sat on the Council of Scientific Affairs with the ADA on this, but the question is changing when to restore teeth, like incipient interproximal lesions. We know about IC-DOS, or the ADA caries classification system, and we're looking at pits and fissures. I think we're all have seen or familiar with, the IC-DOS code from 0 to 6. When do you start treating that fissure? When does it truly have, when does it truly need to be treated, and what have you? And there have been a lot of scientific studies on how these lesions progress. We know how long it's safe to watch and wait, or what we can seal and can't safely seal. I mean, we've established all that in the literature. What's changing is, from this, is not just the fissure, but also interproximal. And what we now know is that these, when I took the dental board, I mean, everybody looked for an E1 lesion. That was the perfect amalgam class 2 preparation, and we all put fillings in these teeth. And I think, the boards are changing as well on this standard, but we know now that even a D1 lesion, like you see on this image, 85% of those are not cavitated. And if it's not cavitated yet on that interproximal surface, we have the opportunity to remineralize it and repair it, and maybe not ever have to restore it. Now, once you get to the D2 lesion, with the red circle around it here, that is cavitated. That does need to be restored. It's early cavitation, and obviously you don't want to get into the D3, then you run the risk of, irreversible pulpitis. But instead of restoring at the E1, we need to start looking at somewhere between D1 and D2, and I'm looking at that thinking, okay, and what is the patient's caries risk? Because I'm probably going to be more aggressive on a patient that has increased caries risk than I am on a patient that has low caries risk. And then again, you bring in the patient's autonomy. They need to understand, you can repair this, but here's, realistically, you're going to need to floss this at least once a day. You're going to need to use a stronger fluoride gel, and you're going to have to do this every day. And if you do that for 6 months, I've actually seen some of these lesions start to remineralize radiographically, and so that that radiolucency starts to reduce, or at least become stable. But again, the patient, needs to participate in this, and they may just say, you know what, I'm not a flosser, I'm never going to be a flosser. Doc, you just will fill it now because I know that I'm not going to be successful at that. And, you know, you have the opportunity to have that conversation with the patient. I think that most of the patients I have this conversation with now in my practice want the opportunity to try and repair it themselves. And I know that it's not, in the average mouth, it's not going to turn into a root canal between the next checkup. And if I'm comfortable with that, then, you know, we have that conversation and we show the patient how to remineralize it and give them the opportunity to repair it themselves. But that's a changing standard. This is a moving target. And at this point in time, this is recommendation from the ADA. So you got the issue of undertreatment and overtreatment, but we know that like a lesion like this, that it's possible to remineralize that, and I see that routinely in my practice. So I want everybody to be aware of that because that standard has changed at this point in time. Then one of the hot topics for the last 2 years has really been silver diamine fluoride, and this really plays into the next topic. But, you know, we have limited evidence, although it's a growing body of evidence, that silver diamine fluoride can arrest lesions effectively, both in children and also adults. And so I've been using this for 2 years. I know that many of you have as well, and I've seen some amazing results with this. Now, the thing that you have to be, you know, again, honest and truthful with your patients about is, you know, here's a patient, and this is what happens. This is what these look like. It's going to turn from the dark brown, soft yellow dentin, you know, lesion, demineralized zones into like a hard, shiny black lesion, you know, on the teeth. And some patients are going to accept that, and some patients aren't. You know, but they need to be aware of that. I you know, just had a colleague over the weekend email me and said, you know, I've got this patient. She's a sedation patient. We did this silver diamine fluoride. She was really unhappy with the, you know, particularly in the aesthetic zone, and so she wants me to restore those teeth. You know, and so I gave him advice on, you know, what to do, what step next to take. But I got to tell you, silver diamine fluoride gives us an opportunity to just get all our fingers in the dike, and then go back once we have it arrested, work out what caused that in the first place. Make sure that the patient understands it, can make the changes that they need to make, and then we can have the opportunity to go back and restore these teeth, and then have a long-term predictable outcome. You know, it comes at the expense of having black spots on the teeth, but certainly it's a minimally invasive, non-invasive technique. I'm using it on senior patients. I'm using it on children. You know, and the scientific review that was published this last year in Compendium concluded that it's safe, effective, efficient, and equitable caries control that potentially has broad application. So I think that's something, again, that there are opportunities, like we talk about ethics. You know, you got the patient that's 95 years old. I mean, I've got a lot of these in my practice, but I can think of one in particular, and he had a lot of decay, and you know, he'd had really fine restorative dentistry done over his lifetime, and now he had decay around all these margins. And it's like, he had the money. I mean, it wasn't a matter of, but really, do you want to put a 95-year-old through recrowning all their teeth and worrying about whether or not, you know, home care was an issue? He was, you know, he had a great caretaker, but, you know, that's a challenge. And all I wanted to do was keep this person comfortable and out of trouble. And I didn't want to have to redo all the dentistry. I didn't want to have to put them in a denture. I didn't want them to have to go through that. And, you know, that's, for me, is the most ethical way to treat somebody like that. And with small children, again, the same thing. You've got the patient, the 3-year-old, that is going to be a sedation case, a hospital case. Maybe if the parents are okay with having some black spots on their teeth, and I don't know why we just went to sleep here. Thanks for joining the meeting. But again, that 3-year-old patient, or maybe the 2-year-old patient, if you can get some silver diamine fluoride onto those spots, you know, perhaps you can arrest that lesion for a couple of years and then get back at a point in time when they are have matured and are capable of you know, sitting in the chair and having some work done. Let's just go forward one more. Okay, so there was a blank spot there. All right. So we're one minor technical difficulty, and we're back online. And this is a paper that's been profiled, and it will be and it's been submitted for other publication. But, the question has always been, so what causes that black stain on the teeth? Why does it get so hard so quick? Is it remineralized? What's happening? And these two researchers have worked out that it's actually the silver precipitates within the dental tubules and creates these silver wires, which are very hard. They're also antimicrobial. The silver ion is extremely antimicrobial. So number one, it immediately hardens the surface, and then number two, it provides this long-term antimicrobial stability as well. So I think you're going to see this is really a exciting research in my mind. We're starting to understand how the silver diamine fluoride works, and it really is a function of these silver microwires, but also explains the black tattooing of the surface as well from the silver. And that brings us to this case. I don't know how many of you saw Megyn Kelly's, and I missed it, but I knew it was coming up. I actually got a notice, an email that this was going to happen. But this little girl that died in June in Sacramento from anesthesia. She went to sleep and basically her heart stopped, and she died. And she was 3 years old, and they were doing just some pretty routine dental procedures. I would hate to have been the anesthesiologist or the dentist that day, because it's really beyond their control. They didn't do anything wrong. It's just that there's a morbidity, mortality with general anesthesia and sedation, and particularly with children. And so this is always, I think this is always in the back of the mind, I think, of any pediatric dentist, and these people love children. They don't do this looking for this outcome. I mean, pediatric dentists love children more than anybody. You have to be a pediatric dentist, and they are the most caring, loving people that I've met in our profession. And so this is a real tragedy for everybody. I mean, there are just no winners here. And, now the family's looking for answers, and of course, Megyn Kelly, this was the hot topic on her show on Sunday night, and again, this is going to get a lot of press, and it's going to reflect, they're going to, question what we're doing as a profession. But I think that one of the things that we need to look at is, with Carrie's risk assessment and education and silver diamine fluoride, could we have provided an alternative for some children that maybe they don't have to be exposed to the risk of anesthesia? So I think that you may see some of these things change in time, but certainly this is always a tragedy. And I just think I've treated a number of children in my practice with silver diamine fluoride, and very successfully. And again, it comes at the cost of having black holes in the teeth wherever they have decay, but certainly it certainly is an alternative. It's certainly another option for care for the parents to be involved in that decision. So anyway, it's a sad moment, but you're going to hear more about this, because when Megyn Kelly starts talking about it, more people are going to pick it up. And if I Google searched it just yesterday, you get pages of information now over this. And then I'm going to leave you with this one last thing, and this just came out last month in JADA, and about third-party adjudication of dental benefits. And this is as Donald Trump would say, this is huge. This is a huge new ethical dilemma, because there's a new category for a benefit decision by third-party payers, and it's called disallowance. It's not that they've declined or you're not covered. They have disallowed the benefit, which means that you, being in contract with that insurance company, accepting it, cannot provide the care, period. You can't provide it for the patient and charge the patient. The patient can't get it out of pocket. Once this third-party adjudication says it's a disallowed procedure, you and I no longer can provide that procedure to that patient. That patient no longer has autonomy to say, yeah, I understand my insurance plan doesn't cover that, but I want it. That's something that I want. And I think this is going to be a challenge for our ethical consideration, because they've taken that autonomy and your clinical judgment out of the entire equation. And I think this is outrageous. And I think that we're probably going to see the ADA working on this to try and change that, because now suddenly the insurance companies are making treatment decisions, and they're not just adjudicating benefits. And there was a time when the people that were reviewing claims in the insurance companies were experienced dentists, and I I don't believe that's probably the case for all dental insurance plans today. So that's one of the biggest ethical challenges I see in front of us, is that, you know, insurance companies are going to be more and more involved in making the determination and taking your clinical experience and decision making and the patient's autonomy out of the equation. So I think we as a profession need to challenge this. You know, we look at, you know, I talk about this standard of care is evolving and changing, and I mean, I've actually been practicing 38 years now, and when I first started practicing, I actually did a few dental implants with an oral surgeon. So this would have been like in the early 1980s. We did some blade implants and some bar implants. I did on patients that wanted it. They knew the risk. We talked about the risks and benefits. But I think dental implants, you know, 35 years ago were somewhat experimental. You know, today I don't think anybody would question the fact that a single endosseous implant is probably our best restorative treatment for a missing tooth in a given patient. I mean, depending upon, you know, the clinical presentation, but I think we would all agree that that's no longer experimental at all. In fact, insurance companies, you know, I think universally or at least routinely cover that as a benefit as well. So we have 15-year outcome studies. We have all this. So that standard of care has changed over time. But again, that's been a, you know, a 35-year process. So, you know, CAMBRA may be fully a 30-plus year process, but it's certainly, I don't think the question is not whether or not you're going to be practicing CAMBRA. The question is, when are you going to be practicing CAMBRA? If you're not practicing, and I know I'm probably preaching to the choir here tonight because of the hundreds of people that signed up for this, I know that most of you are already involved in CAMBRA at some level in your practice, and you're curious about, you know, where does it stand from a standard of care or legal standpoint. And there, you know, I can't give you that answer, you know, definitively in black and white, but I can tell you that it is standard of care in my practice. That's how we treat things. It does have all of those features of a best practices technique, and so, you know, then it's your ethical decision that you have to make, whether or not it's part of your practice and how you're going to share that with your patients, and maybe share it with our colleagues as well. So I'll leave you with this, you know, act ethically and carry on, and I know that you all do that. At the end of the day, this is all about balance in your oral health, balance in your life. And so I know that we have time actually for a few questions, and I hope that you enjoyed this information. I hope that it added to the knowledge that you had on ethics and legal standards and considerations. I think it was timely, and I hope that you know, I hope that you found this valuable.
Yes, great information. Thank you, Dr. Kutsch. So we have had a few questions come in. Let's see if we can get some of those answered. So the first one, dentist wrote in, being able to successfully implement CAMBRA for patients sounds like it hinges around the dentist's ability to communicate. Do you have resources you can recommend to learn how to better communicate this philosophy and more effectively communicate it?
That's a really, those are great questions. That's a great question, because I got to tell you, when I first started practicing CAMBRA, I mean, I sat in my hygiene operatory with the patient and, you know, went into a long scientific explanation about mutans, streptococci, and lactobacillus, and I probably lost the patient after the first 20 seconds, and I lost my hygienist after the first 3 or 4 minutes, and it really is a function of, you know, simple communication, just being honest, being yourself, and using simple analogies. You know, one of the first analogies I brought up was the nail on the tire, you know. So there's some simple models like that. Certainly the team of our trainers here at Carifree can help work with you. I mean, they're a great resource. I mean, in fact, they're probably the world's best resource at communicating CAMBRA with patients. I would tell you that personally I went through a coaching, wellness coaching workshop. There's a number of books out on wellness coaching, and they really are good at helping improve your communication skills in terms of, you know, being able to talk to the patient about benefits and doing all that. And understanding that you're putting the work, you know, on the patient. You know, this is their teeth, this is their problem, and I'm in your corner as your coach, you know, helping you make decisions. But, you know, at the end of the day, you know, I don't floss your teeth, I floss my teeth. So being that, honest with patients, I think is really helpful. But I got that from the coaching program. And I've talked about her before, Ferocia Knight, at the Baraka Institute in Portland. I went through a 2-year program with her on wellness coaching. Again, one of the best things that I've done in terms of creating communication skills. But I think that you can buy books. There are a number of books on wellness coaching. The motivational interview, certainly that's another good place to start, and there are a number of books on that. So there's resources there. I know that we did a webinar on wellness coaching. So I think there's resources, but certainly the Carifree team here can literally provide some great resources for you. That's a really great question. I mean, the greatest challenge is, and maybe it isn't just the dentist, but when you really implement CAMBRA fully in your practice, it really depends upon the rest of your team also being able to reinforce or have that conversation with the patient. I depend now on my hygienist to both explain Carrie's risk assessment and then also whatever strategic treatment plan that we agree on to really work with the patient one-on-one, coaching them. So I put them through a coaching program as well. But it's not just the dentist communication skills, it's everybody's communication skills in the entire office. Great question.
Yeah, and Dr. Kutsch, those are excellent comments. If any of you are interested in some of the resources that he did talk about, just reach out to us. We can send you, for example, Ferocia Knight, we can send you that contact information. Of course, we are all here to help as well, so feel free to reach out if you would like some training, refreshers, or you want a webinar to learn from the ground up. And actually, the last part of that answer was a perfect segue into the next question that I wanted to ask you.
Great.
So we had a doctor write in, and they said, I find the most difficult part of moving my practice forward is getting my team on board with new ways of practicing. How do you create a culture of adopting innovation with your team or implementing CAMBRA, for example?
And that's not an overnight that's not an overnight process. I think to create a culture within your practice, number one, you have to have the right people there. And if you've got somebody, you've got a scientific revolution going on there, and you've got some old guard there that absolutely won't change. I mean, they need to die, or maybe they don't belong on they're not appropriate to be on your team. But I would say from beyond that, there's a number of good books, certainly that my team and I have read. Some of them, I mean, some of them were on customer service. But, pick a good business book, and then at your team meetings, like, once a month or whenever you have your meetings, talk about it. Pick a book, whatever topic it might be on, and, go through that with your team. And then I spent a lot of time, I mean, in my team meetings once a month, I spent a lot of time, bringing them up, keeping them up to speed. This is really an evolving target, moving target again. Even CAMBRA has grown. And so continuing to give them the scientific basis and the information, and then share experiences with patients. And so we as a team kind of have been making this movement happen. But it really took, I pushed the ball to start with, it really took my hygienist to get involved. And there's a great book out on tribes. And it's really, we are tribal, and it takes 3 people. So you really need to find a team of 3, core of 3 people within your practice, and that can change. Once you're all on the same page, you can create and change the culture in your practice. But you can't. The dentist can't do it on their own. It really takes a team of people, and so I got my hygienist involved, and from there, literally, I had to get out of the way. I mean, it was really, they took it over and owned it, and now my team. I mean, we're always looking for ways to improve our care. So but again, that's probably been a lifetime theme for me, but it's probably been with CAMBRA. It's certainly been a 17-year process in my own practice. And again, one more thing I would add to that, Lacey, again, is making sure that they all understand it and understand why, what the benefits are for doing that for the patient. What are the benefits for the practice? And again, I would offer up the Carifree team, training team, as probably the world's best resource at being able to provide you with a lunch and learn to help your team completely understand why you want to do this. So I'd throw that out there, Lacey.
Yeah, absolutely. I would say one of the things that we see with our practices, kind of, moving from that slow start to really becoming part of the practice, just the natural way that they're practicing, is once you get a few success stories with patients and you start to build that confidence, it's important to keep those top of mind with your team and to talk about them together, because that's going to help build momentum and help keep that momentum moving forward as you're, working really hard to make CAMBRA the standard of care in your practice. So those are excellent recommendations. So we are a little bit over time. I think if anyone has to break off the phone, you're more than welcome to do that. I do want to ask the last question. I do think it was a good one, and Dr. Kutsch, you touched on this just briefly, but I think it's worth going back to and talking a little bit more about. So if I implement CAMBRA effectively, will my practice remain profitable? I know that's, taking the leap of faith. That's a big one, a big question for a lot of practices.
Yeah, and that, and Lacey, I get that question a lot, and because it's like, how do I charge for this? How do I make money doing this? It's like suddenly you look at this and go, okay, so I could have done a bunch of restorations on this child, and now I did some silver diamine fluoride instead, and my own fee for silver diamine fluoride per tooth is the same as a sealant fee, so it's about $50. Versus, I would have made a couple $100, $250, or $300 on a restoration. So you look at it and go, oh, so I'm giving up a lot of income. Doing the right thing for the right patient at the right time is always a win-win in your practice. And I tell you, when you treat patients like that and they have that opportunity to have those kind of options or care, and certainly for patients that, I've, had some extensive dental caries, and it wouldn't have been illegal to have just gone in and done a complete restorative treatment on them. I mean, that's what I was trained to do in school. But in my opinion, today that would be unethical without first going through understanding and having the patient understand, us diagnosing what's causing this problem, and so giving them an opportunity to figure out how to correct that so that they can be healthy and then maintain the dentistry that, the fine restorative dentistry that you're going to do for them. So that really becomes kind of an ethical decision as well. But I would tell you that once you have those success cases, I've got a patient that I couldn't even tell you how many people he's referred to me because of what we did for them. And the amount of, I guess I'm trying to describe this, but it's such a profound experience for patients when they stop getting cavities, that it's emotional and it's profound. And that has created like more new patients and my practice is thriving, and it's all based around doing fewer restorations and doing more diagnosis and doing more teaching on prevention. And then my practice has grown financially because we're doing a lot more large restorative cases that patients are asking for. So, and that I know that, certainly they're indicated, they can afford, and now I also have the confidence to know that, we're going to have a long-term predictable outcome because I know that this isn't going to come back in here with, 22 new lesions around these restorations that I just placed. So, like a year later. So, it's a win-win. Anytime you do the right thing for your patient, it's ethically you win. And at some point in time, that's going to show up in your bottom line. I guarantee you that.
Awesome. Well, I think that wraps it up for the evening. Thank you, Dr. Kutsch, for all of your insight. Thank you to everyone for joining us tonight. Any questions that we didn't respond to, we'll answer in the next few days. And if there's a part of the webinar that you do want to hear again or you missed, we'll be sending out a recording soon, so be on the lookout for that. And please, again, contact us if you'd like to schedule a webinar to go over CAMBRA, to talk about the Carifree system specifically. And just thank you all and have a wonderful night.
Yep, everybody have a great summer. Thank you for your time. It's really appreciated.